you absolutely must self-educate. You must watch the Metabolic Mind videos with Mark Horowitz and Dr. Joseph. If you are able, if you're a reader, I want you to get the Maudsley deprescribing guidelines. I want you to understand that general hyperbolic tapering practices means we go down in small percentages of 5 to 10% as opposed to milligrams. I want you to understand that the last few milligrams of any medication are particularly treacherous and must be done in a very thoughtful and careful manner. And the reason this is so heartbreaking when I watch this happen and why this makes me so mad is because the person who I have watched be beautifully recovered for months suddenly is just shooken to their core. They're not sure if their recovery was ever real at all. And they have a prescriber looking at them square and saying, look, this means you needed that medication all along. And I just think it is the biggest gaslight. And I'm so upset about it.
Hello, everyone. This is Nayiri from Low Carbon Fasting. Okay, as you can see, there are 3 of us here today. So I have a co-host today. Now, my co-host is Dr. Erin Bellamy. I've interviewed Erin before. I will put the interview link below in the description so you can check that video out. Thank you for accepting to be my co-host, Dr. Bellamy.
Yeah, absolutely. It's a pleasure to be here, and I'm excited to chat with Nicole today.
Okay, so who is my guest? Our guest today is a licensed mental health counselor. She uses the ketogenic diet as a therapy for mental illness and neurological issues, and we'll discuss all of these later. She uses, this is according to your website, now she uses nutritional and functional methods. We'll clarify those later on.
Yeah.
And she is, so she holds a bachelor's in psychology and master's degree in clinical psychology and a bunch, as the Americans would say, Erin, and a bunch of certifications. But I thought I'd mention certifications in nutrition and integrative health. She's also the author of numerous publications. She has won an award from Metabolic Mind. What resume? Nicole Laurent, welcome to Low Carbon Fasting.
Yeah, thank you for having me. Glad to be here.
Okay, I think, Nicole, so mental illness and neurological diseases, aren't they the same? What's the difference for anyone who's an outsider like me?
They're really just the differences in how people conceptualize them. Problems with the brain show up in different ways with different symptoms, but there's still problems with brain health. And so I really just put that down because some people have not grasped that yet for themselves or when they think about these different diagnoses. And so if I focus on saying that I'm working with mental illness only, then my Parkinson's and Alzheimer's people won't know to come to me. And if I say I focus on neurological, then my schizoaffective disorder and my treatment-resistant depression won't find me. And so it's just terms that are used in the medical establishment that people identify with and help them find their way to me.
I was going to ask, what diagnostic criteria do you use for mental health conditions? Is it just the DSM assessment? Because
we use a DSM-5, and within and the DSM-5 is supposed to inform the ICD-10 codes, which are now used instead over here in the US. But yeah, that's generally what's been used in psychiatry is the DSM-5.
Okay, nutritional and functional methods.
Nutritional and functional methods.
Or therapies.
Yeah. What, did you have a question or should I just go for it with that?
What are we talking about when we say you use nutritional? Well, I understand, my understanding of nutritional therapy is that you try to implement some form of ketogenic or low carbohydrate or lower carbohydrate, sometimes put it, lower carbohydrate diet, depending on context, obviously. But what is functional therapy?
Functional. So functional medicine is where we try to catch disease processes early, or we often will look. So I'm not a functional medicine provider. Those are MDs, and those are nurse practitioners, and those are people who have additional training in functional medicine and provide medical care. My training is in functional nutrition and integrative health. And so there's two ways to kind of think about this. So there's nutritional therapies, and there's metabolic therapies, and there's a crosstalk between the two. And so that can become very kind of confusing for people. So nutritional therapies, nutritional psychiatry, nutritional psychology, I guess you would say, these are fields and areas that look at things like, how do particular foods affect mood? What are the effects of the gut microbiome on mood? What stark nutritional deficiencies or insufficiencies are going on that makes it difficult for the brain to function or the body to function and to do what it needs to do to keep chronic disease or chronic conditions at bay, right? And particularly as it relates to cognitive and mood symptoms. So, and when we think about metabolic psychiatry, metabolic psychology, I guess, which is not really a term quite yet, I use the term metabolic psychiatry for non-prescribers, a non-prescribing metabolic psychiatry practitioner. And I do that because I want to be very clear that I'm a non-prescriber. There's a confusion with the word psychiatry nowadays because it has been so overwrought with medication focus that everyone, when they hear the word psychiatry, they think, oh, medications, they prescribe medications. But really, that is not the foundation of that word. So metabolic psychiatry, metabolic treatments are about mitochondrial improvement of function. And by all means, micronutrients play a part in that. You can put someone on a low carb or ketogenic diet and switch their fuel sources, but they still absolutely have to have adequate amounts of vitamins and minerals and the basic things that mitochondria need to function well in order to get full effect. So they've got a crosstalk, and it's a little bit confusing. But I think about metabolic psychiatry as and Georgia has talked about this in her podcast recently, rebooting a brain. Georgia Ede. It's like a brain reboot. It's a shift in energy source and an upregulation in energy. And then the nutritional component is a piece of that. So kind of, I don't know if that answered the question, but that's the gist of it.
That clarifies it. But I mean, one word there I like, and I'm going to come to you, Erin, integrative health. Erin, tell us why that word is so relevant to what you do. So can you very briefly introduce yourself as well, and tell the audience what you do, or listeners what you do?
Yeah, absolutely. So I'm Dr. Erin Louise Bellamy. I am a metabolic psychiatry clinician and researcher, but I am a chartered psychologist. So again, a little bit to what Nicole was saying, I'm not a psychiatrist, but I use principles of metabolic psychiatry in the work that I do with people. And my private practice where I see clients is called integrated ketogenic research and therapy. And I suppose that's why you're asking me why that word is so important. And again, it's because you're pulling together not only putting people into a state of ketosis and switching their fuel source, like you said, Nicole, but there are so many other avenues that you need to go down in other disciplines that you need to pull together in order to really help somebody improve their overall brain health. And it might be that you need to look at nutritional deficiencies, or you might need to look at other metabolic therapies and pull those together as the bigger picture. So that's what I do, and that's why that is so important. But I was wondering with Nicole, because you kind of balance the two areas and you do that really well, how often do you find somebody who has a nutritional deficiency that likely, they might have gone on a ketogenic diet or used ketogenic therapy, and maybe they wouldn't have got very far because of that nutritional deficiency? Do you see that often? And obviously it's a good thing that you're able to pick it up early on.
Yeah, well, really, we do you can do a lot of testing in the beginning before someone starts a ketogenic diet, kind of trying to ferret out those issues. But a lot of the blood work and a lot of the stuff changes after 3 to 6 months, right? And so my practice is to put people on a good multivitamin, a good basic but good forms of particular micronutrients. And I always have people track. So I do a nutritional analysis to kind of see what they're getting. And once I put them on a well-formulated ketogenic diet, to the best that they're willing to go on, then we reassess from there. But yeah, I have people who come in looking for a ketogenic diet that are clearly anemic, who are clearly not eating enough protein, bioavailable protein. Their amino acids are low. You need those to make neurotransmitters, right? And so there's, I've had people with B12 deficiencies. I have people often with just rock bottom low vitamin D levels that should have been picked up many, just low hanging fruit, right? Some vitamin D,
Yeah.
So lots of times I get people who we begin a ketogenic diet and we just start increasing micronutrients from the very beginning. Yeah. I don't think someone with a vitamin D of 15 is going to thrive on a ketogenic diet, no matter how ketogenic I make it, what ratio I put them on.
Yeah.
They need the supplementation. So when people come to you, Nicole, do you, I presume many of them are on medications, because these days they're so easily prescribed.
Yeah.
I don't know if you would disagree with that, but in my opinion, from what I see, they're just so easily prescribed. So when they come to you with medications, what path do you take with them?
Well, I'm not a prescriber and I don't fiddle with that area. I'm very conscious of professional roles and ethics and my scope of practice. And in fact, the majority of the people I work with as a private consultant out of Washington State, where my license is. So in Washington State, my work is often under my license as a mental health counselor. And I make a very stark distinction with my work as private consultation. So, and I don't play with prescriptions in either of those, and I don't give advice around that. But one of the ways I work with that is first we look at, are there any medications that, in the epilepsy world, they've identified get in the way of a ketogenic diet or can cause more side effects. So we do screenings for that. And that's mostly just, you as a private consultant, you really don't get to talk to their doctor one-on-one. So a lot of my work is teaching people how to self-advocate. So often I'll give them general information that they can ask their doctor about to see if their doctor feels like that's going to be an issue or not. And then the other big thing is I help people kind of watch for potentiation effects. So as the longer people are on ketogenic diets, in their current medication dosage can become too high and cause side effects for them. And many people at that point will think, oh, my ketogenic diet has stopped working, I'm just going to give up on this ketogenic diet. But really what needs to happen is their prescriber needs to potentially adjust down or use a different medication or help them in some way make some kind of medication adjustment. So I help them watch for that and kind of keep that in mind and have conversations about that. And then the most important way I think I am helpful around medication as a private consultant and a coach in a coaching role is I tell them, please do not assume that your prescriber knows how to titrate you down in a safe and effective manner. And early on, because I was so very careful about my professional role and my scope, I would have never challenged that. I would have said, oh, just work with your prescriber. They know everything, right? It's all good. But I don't do that anymore. I think that was very naive and very unhelpful. I didn't want to get in that area at all. But since then, I have seen beautiful ketogenic recoveries, just solid remissions, solid thriving, solid recoveries. They're doing so well. And they go to their prescriber and they're like, I'd like to get off this medication. It's clearly not adding value to me. the prescriber is very sure of themselves and does a reduction. And even if the patient is like, oh, I don't know, that seems a little fast to me, they will argue with the patient and they'll be like, oh no, you're not going to get any titration effect, you know, any problems. You're going to be fine. And I have seen repeatedly a complete derailment of beautiful ketogenic metabolic therapy recoveries because of prescribers' poor tapering practices, which, as you can imagine, makes me very frustrated and very angry. And I've been on a bit of a tear about it for a while. And so one of the things I will tell people is you absolutely must self-educate. You must watch the Metabolic Mind videos with Mark Horowitz and Dr. Joseph. If you are able, you know, if you're a reader, I want you to get the Maudsley deprescribing guidelines. I want you to understand that general hyperbolic tapering practices means we go down in small percentages of 5 to 10% as opposed to milligrams. I want you to understand that the last few milligrams of any medication are particularly treacherous and must be done in a very thoughtful and careful manner. And the reason this is so heartbreaking when I watch this happen and why this makes me so mad is because the person who I have watched be beautifully recovered for months suddenly is just shooken to their core. They're not sure if their recovery was ever real at all. And they have a prescriber looking at them square and saying, look, this means you needed that medication all along. And I just think it is the biggest gaslight. And I'm so upset about it. So while I'm not a prescriber, we talk about medications for sure.
Yeah, hearing that, I mean, I'm sitting here, I was just getting so frustrated on their behalf. It's what's the solution? What do we need to do? We obviously need to educate prescribers about metabolic psychiatry, right?
Mm-hmm.
We've got
so much cool stuff going on behind the scenes around. I know of at least two prescribers that are working on ways to train prescribers about the use of ketogenic diets and medication and safe tapering practices exist. So the Maudsley deprescribing guidelines, those have been adopted by, I'm not going to say the professional organization correctly, but the Australian Psychiatric Association and the British Society, Erin?
The British Society of, has it been? I'm not sure if it has been.
There's the psychiatric, the Royal College of
the Royal College of Psychiatrists.
Ian Campbell would know. Ian would know. He spoke there. So those have been adopted by both of those organizations. But here in the States, nah, just go off the last 10, 20 milligrams of your antipsychotic, you'll be good. And that can cause rebound psychosis, which again, when my poor client gets psychosis or starts to get symptoms again, they really start to question whether they needed the medication at all, when really that might not have happened. It might have, but it also might not have. And we might have just derailed their recovery.
Mm-hmm. I think
do you see a change coming? Sorry, Erin. Do you see a change coming? Yeah.
Oh my gosh, absolutely. So just like metabolic psychiatry is a kind of a grassroots patient-led movement, with plenty of practitioners trying to put the collaborative components in place for them to get treatment and to have it be covered by insurance and to get the RCTs and do the research and expand the knowledge of clinical practice. I think that the part about the tapering and the titration is going to come along with it. So these people are learning to self-advocate. They come to me all the time. I've heard about this. I feel like this would work. I want to try this. What do I need to do? What do I need to learn? And I think they're perfectly happy to learn some of the basics about how to self-advocate around titration.
Mm-hmm. Yeah. One of the things I think that's really coming through, and it's what I see as well, is the fact that because it's grassroots movement and they are advocating for themselves, it brings with it so much more strength. Like the training is going to be there for the psychiatrist eventually, and I mean the Maudsley deprescribing guidelines are already there for people to pick up if they want to learn. Even if they are psychiatrists already, they can do that. But a lot of them are not doing that right now. But when you have a client or a patient that comes to you and they are either advocating for themselves or you support them to advocate for themselves, then they really do feel like they are in control, which is, you know, often not something that they have felt in terms of their mental health care. So I think as long as, you know, as psychologists, you know, we're not training the prescribers, we can train the non-prescribers, but we can continue to support people to advocate for themselves so that they become so loud about what they need and the support that they need that nobody can nobody can ignore it.
Nobody's gonna dissuade them.
Yeah.
That's, you know, there is hope, there is light in the horizon. Nicole, give us a profile of your sort of clients. What sorts of conditions do they come to you with?
Yeah, so lately, the majority of my clients seem to be schizophrenia, schizoaffective disorder, bipolar disorder. I do get treatment-resistant depression. I do get OCD, and I do get eating disorders from time to time. But part of why I'm front loaded with those diagnoses is because I assisted a famous YouTube person, Lauren Kennedy West, on the Living Well with Schizophrenia YouTube channel. And so she has been very active in talking about metabolic psychiatry and metabolic therapies and how that has put her in remission. And she is now deprescribed from medication and is beautifully stable and thriving. And so she has a new channel called Living Well After Schizophrenia. And so she talks about this all the time. And so she mentions me. And so I get a lot of people from that channel specifically. I think, Erin, what does yours look like? Do you get that many of those diagnoses, or do you get a different amount?
Oh, I think mine's more so balanced equally. I don't get that many. It's probably, actually, maybe that's a lie. I think it's predominantly bipolar, but I don't know if that's because you know they're the ones with maybe there's a higher diagnosis rate in the UK, although I do see people worldwide. But I don't get that many people with schizophrenia and schizoaffective, just a couple here and there. So it might be because of the work that Laura's done that you're
Yeah,
getting.
I'm very skewed right now for who I work with.
So with all these conditions, so where do things like autism or ADHD come into these diagnoses?
Do you want to go, Erin?
Sure. So when it comes to the work that I do, I don't work with people who have a diagnosis of autism only. I know there's a lot of research to support using things like a low carbon ketogenic diet for those diagnoses. But sometimes I work with people and it's their secondary diagnosis. So they might come and they have depression and anxiety, and that's what they really want to work on, but they also have autism and perhaps ADHD. And so often it's comorbid, and then we can work on it, and there are some aspects that maybe don't improve, but generally speaking, people do improve across the board, especially in terms of their quality of life and their ability to get things done. And then with ADHD, sometimes I have people who come specifically with ADHD. They say it's for anxiety, but then as soon as I speak with them, ADHD is the main thing that they're dealing with. And I've seen that people respond really well to a ketogenic diet if they have ADHD. And even have people say that actually it seems to give similar effects to some of the medications that they may have used previously that perhaps they were sensitive to. So overall, pretty good results across the board for those conditions. What do you see, Nicole?
Yeah, so I'm kind of like you. If the primary diagnosis is autism, and autism is a spectrum, and there's varying levels of functioning within that spectrum, and so I don't generally take just kind of a pure autism type of diagnosis. I generally will send that to Denise Potter's group. because her dietitians have such experience in working with that type of population. So they often will have really kind of limiting food choices, and that really every population kind of has its own, you get good at working with certain aspects of each population and kind of understanding how to work through that. So I choose kind of that dietitian group for that, Denise Potter's group for autism. But yeah, everybody that comes to me with one diagnosis has two others. And then I also work for neurological, I do work with Parkinson's disease, stage 1 Alzheimer's type of diagnoses, mild cognitive impairment. There's a huge neurological component to PCOS. So the brain fog, the cognitive symptoms that happen as a result of PCOS are actually neurological in nature, as opposed to hormonal. And so that diagnosis really does improve on a ketogenic diet quite substantially. And so, yeah, it's not like, I think Erin would agree with me. While our patients come to us with these diagnoses and really highly identifying with those diagnoses and really truly feeling like that is a very specific thing, when you're not focused on medicating the symptoms of that very specific thing, and you change your paradigm into how do I improve your brain health in such a way that your brain is functioning. And here's the question. If we fix your brain and your brain is healing on a ketogenic diet, which is not a crazy thing to say because they've been using it in epilepsy for over 100 years to heal a brain, right? So this should not be a groundbreaking thing I'm saying. So if your brain is healed and you don't have those symptoms anymore, did you ever really have that special particular diagnosis? I'm not so sure. I mean, is that a useful paradigm? So I think about brain health, and I think about what are the components around hypometabolism for this diagnosis? Do we see glucose hypometabolism in this diagnosis? Do we see neuroinflammation? Do we see increased risk of oxidative stress? And do we pick up certain neurotransmitter imbalances? Like, is there a GABA glutamate imbalance that's in the literature for this diagnosis? And if the answer is yes, then I'm going to focus on the cure. I'm not going to really super hyper focus on what percentage autism you have versus your ADHD versus your major depressive disorder, because they've already done that to the moon and back. Like, they have already been so diagnosed. And so, like, it's not useful. It's just not useful for people recovering. It's not a useful paradigm, in my opinion.
Yeah, I second that completely. Once people start to just look at how they're feeling and how what they're doing is improving all of their symptoms, doesn't matter what the symptom, which diagnosis the symptom is tied to, once they start to see that the symptoms are improving, it doesn't really matter, what diagnosis it is. They're just healing and they're feeling better and they're able to do more.
Would you say that in the current sort of standard of care, or in the current sort of Western medicine, we're over-diagnosing and over-prescribing? Yes, is that correct?
Yeah.
That's the impression I'm getting.
Isn't that obvious? Yeah, that's like super obvious. Yeah, it's super. Even the patients will come and say, I've got, 5 diagnoses and 4 medications, and this is not helping. Yeah. Yeah.
And the interactions in the medications as well. Like, often you find you might have somebody who says, I have these diagnoses and I'm taking 3 or 4 medications, but there might not be any research on how those medications actually interact with one another. So there's research, of course, on each individual medication, but that person may have been on 3 all at the same time for a period of 5 to 10 years, and they're feeling it. They have their initial symptoms and then the symptoms of how those medications combine. So that's a whole nother thing.
Polypharmacy is not a very evidence-based practice.
Yeah.
So we talked of the different sort of diseases or conditions, I guess, or disorders that people come to you with. But what age group do you see, Nicole?
Oh, well, so I in both my private practice in Washington State as a licensed mental health therapist, and also in my private consultation as a non-medical or mental health provider, um, you get teenagers. I got teenagers. Their parents are helping them track the macros. Their parents are assisting them. The kids are on board. They want to feel better. I got a few where the kids aren't on board and their parents are doing it with them anyways, which is more tricky. But yeah, I get people kind of all ages. I think, I have a 70-year-old I'm working with, right? Because I'm working with my MCI and stage 1 Alzheimer's and Parkinson's. And so yeah, there's brain disorders in all ages, and they are coming in droves seeking this treatment out and looking for assistance.
Right. So what makes the ketogenic diet work? What is it about? Is it the ketones?
We're trying to figure that out. That's part of all the research hubbub going on, which is really kind of interesting. So, in the epilepsy world, they know that there's a gut microbiome overhaul that happens in about 2 weeks on a ketogenic diet. And they think, my understanding is that they think that the gut microbiome change that occurs is a part of the mechanism that creates a neurotransmitter improvement in terms of increasing GABA and reducing glutamate. So I think that's super important. That could be what does it. I think that mitochondrial functioning improving is huge. Ketones are molecular signaling bodies, and they have what's called pleiotropic effects. So the improvement in mitochondrial function and the improvement in, the epigenetic expression of genes is very helpful. Like glutathione has been seen to be upregulated in ketogenic diets. There was a beautiful poster. I wish I could find that researcher again. It was one of those situations where I took a picture of the poster and I blew it up, and I couldn't get contact with him again, but he was working at a hospital, and he had actually, he found that glutathione levels in the brain for people on ketogenic diets were 7 to 10 times higher. What does glutathione do? It's an endogenous antioxidant, the most powerful one. You're just not going to get enough vitamin C in your body that does what a good dose of glutathione does. So, I mean, there's so many effects. I think we're going to be looking at this for a very long time about all the different effects that happen with ketosis. And some researchers are beginning to suggest quite boldly and wonderfully, I think, in their papers, that it's the absence of ketone, the absence of periods of ketosis that are destabilizing organ systems. And that maybe that we're supposed to have at least sustained periods of ketosis from time to time for that. And so, gosh, that's like the $1 million question. If you could figure that out for us, that would be awesome. Yeah.
One thing on that is that I'm so glad that within the metabolic psychiatry community, we have people looking into these mechanisms at the same time as us being able to actually apply and implement ketogenic therapy with people. Because when I think I might have said this last time we spoke, Nayiri, when I was doing my PhD, just looking specifically at ketogenic diets and depression, I found like 53 or 54 mechanisms alone where you have a mechanism of depression and then you have a counter mechanism of ketones where the ketones will kind of cancel out that mechanism of depression. And so that's only for depression, and that's not all of them. So if you think about all of the different mechanisms of each individual diagnosis and try and figure out what the counter mechanism would be, when using ketones, and then you took a year to look at each of those mechanisms, we're going to be here for hundreds of years, and we can't wait that long before we help people. So, we've got some fantastic brains in the metabolic psychiatry research space now that are looking into that, while, us as clinicians and researchers can actually help people.
Nicole, you mentioned some like glutathione, obviously, and GABA. I know they come in supplement forms as well. So are they useful? I mean, would you prescribe GABA
well,
supplement?
that's more of like a functional nutrition question. So, oh gosh, that's a whole thing, whole rabbit hole. I can talk about that though if you're interested. So GABA,
I'll tell you why I'm interested, because
yeah.
I've got the perimenopausal brain, and of course I don't like making jokes about it, but you have to laugh. And wondering if GABA would be useful.
So yeah,
Because
so if
I read
the
about it, that it
blood-brain
might be.
barrier, oh, I'm sorry, I didn't say that again.
I read that it might be useful. So
Oh, well, yeah. So if you have an intact blood-brain barrier, which most of us don't, you know, then taking GABA won't work because it won't cross the blood-brain barrier. So your neurotransmitter system in your brain is not exactly the neurotransmitter system in your gut, but they do crosstalk and they do influence each other in different ways. So if you have an intact blood-brain barrier and you take GABA, my understanding is that you won't feel any different. But if you have a blown open blood-brain barrier, which many of us do, there's lots of assaults on the blood-brain barrier. Then if you take GABA, you will definitely feel it. And so that's that one. You know, there's also supplements that people use that help their body make more GABA. So L-theanine is a plant-based amino acid. It's the method of chill in a cup of green tea that you get is that L-theanine, and that's not making GABA. What that's doing is it is helping the enzyme pathway that's used to make more GABA. So that will help you make more GABA, for example. So that's another nice one that you could possibly use. And then in terms of glutathione, I like to provide the precursors to the body's ability to make glutathione as it wants and needs. And so I'm much more likely to supplement someone some glycine and a small dose of N-acetylcysteine possibly, and make sure they have the micronutrients they need that are part of the glutathione cycle. Because again, your body, if it has the precursors, it's going to make the perfect amount of glutathione that you need. Now, if your precursors are very, very low because your nutrition is low, or maybe you don't eat very much protein and amino acids and you can't pull together some cysteine for that cycle, and I just prescribe you a bunch of liposomal glutathione from my Fullscript account and I get a nice little cutback from that, that's not fair to you, because you might actually need more glutathione than you're getting in what I'm giving you. I don't know how much glutathione you need. You're a complicated machine and your body is keeping track of that. And so any functional medicine practitioner that's like, oh yes, you need 1,000 milligrams of liposomal glutathione, they don't know. They do not know what your dosage is. So I much more like to put the precursors in there. Now, if someone, again, all of this very, I know your listeners are like, oh, I'm going to get me some N-acetylcysteine, right? So, but cases are complicated. So if someone, has cancer, for example, N-acetylcysteine can be used by cancer. So don't just go out willy-nilly, doing things like this. But yeah, that's kind of what I do with it. Yeah. And so then if I've got a ketogenic diet on board and I have plenty of materials to make glutathione, it's probably safe to say that I'm going to be able to make what my body needs in order to reduce oxidative stress. And if I'm able to reduce oxidative stress, I'm able to reduce neuroinflammation. And if I'm able to reduce my neuroinflammation, my neurotransmitters are going to be made in a more hospitable environment. And I might make the right amount of GABA as opposed to too much glutamate. So it's just kind of stuff like that is kind of how you think about that. And if that's the case, then my neurotransmitters are functioning better. I mean, ketogenic diets improve membrane potential and membrane function. And so, yeah, many, many aspects that are all kind of intertwined.
If I may, there's one thing that you've just said there, which is that all of these things are intertwined. And if we think about the root causes of mental illness, you know, I guess researchers would come together and agree on maybe 5 or 6 of them, like you mentioned: neuroinflammation, oxidative stress, brain hypoglucometabolism, mitochondrial dysfunction, and all of these. And yet they will then, a neurotransmitter imbalance, for example, and up until now, therapies and pharmacology would say, okay, well, take this pill for that. But we don't know an individual's root cause. We don't know exactly what triggered these symptoms for this individual. Well, most of the time we don't. And also, if you influence one, then you're influencing the other, just like you said. And so the really cool thing, I think, about ketogenic therapy is the fact that it can influence nearly all of those root causes that we know of in some way, shape, or form. So you can start to see benefits across the board rather than trying to figure out, well, what is my root cause, and, you know, what do I need to take in order to fix that? Because actually it will influence everything.
Yeah, that makes sense. So we've got to talk about the ketogenic diet now. So I'm sure, Nicole, you adjust it based on the individual, right? Can you tell us where do you start? What do you tell them not to eat or eat?
Yeah, well, I'm pretty picky because I'm trying to heal their brain. So there's no dirty keto working with me. So what that means is they avoid seed oils. Georgia Ede has written a beautiful book, and you know, one of the things that she talks about is how industrialized oils can increase oxidative stress in the brain by how they're kind of burned improperly up in there where they should not be. So I try to get them off of the, I shouldn't say I try to, because the people who come to me are highly motivated and they are like, just tell me what to do. Just tell me what to do. And so it's not like I'm fighting with anybody to get rid of industrialized oils. I'm just like reminding them, oh yeah, that's one of those oils. And they're like, oh, okay, it's out of there. So so yeah, there's no wrestling that goes on with me and my clients in terms of trying to get them to stop doing anything. They are miserable and suffering, and they are perfectly happy to do whatever I suggest, which is wonderful, like the easiest job in the world. So no industrialized oils, good healthy fats, things like coconut oil, avocado oil, butter, ghee, animal fats, lard, tallow. I'm sure I'm missing some of duck fat, you know, the good stuff, the stuff that's going to build really strong structures, right? And stuff like that. There's great things in eggs. And animal foods, I prefer someone is on animal foods if at all possible. Eggs, at the very least, because the bioavailability is such a big deal. And you know, but I do construct vegan and vegetarian diets. I don't prefer vegan diets. I really worry about micronutrient deficiencies and amino acid deficiencies and omega-3 deficiencies. And I think that if you're trying to save your brain, I think you gotta work around being willing to do whatever it takes to do that at some point, right? But yes, I construct those. And no grains, absolutely no grains. So again, Georgia Ede's book, Change Your Diet, Change Your Mind, highly recommend. If people are confused about what I'm saying, why would she say that? Then you will definitely want to listen to or read that book. It's just absolutely so important. That should be the nutrition manual that we hand high school students, quite frankly, you know, in the home ec classes, if they even have those anymore nowadays. So that's a well-formulated ketogenic diet. And so, yeah, I construct them and I make them track. So, and the reason for that is because someone can eat low carb and not get into very high levels of ketosis, not really understand how many carbohydrates they're eating, not really understanding that having a big giant steak might affect ketone levels for a few hours, which for most brains is not a big deal. But for a brain that's struggling, that can't make energy without some ketones on board, it's a really big deal with ramifications later in the day or the next 3 days. So they got to track because they really have to learn how many carbohydrates are in things. And sometimes that's very overwhelming for people. Sometimes I'll throw them a low carb list and say, do this for a while and get used to it. We start with the, the baby step into it. But ultimately, if you work with me, you're going to learn to track, because I don't want to spend my sessions guessing with you about what's happening. I want to see the data and know what's happening. It's expensive. Well, it's not terribly expensive, but it can be expensive to have these consultations every week to get on board. And then you're like, oh, maybe I ate too many blueberries, or maybe that was too much protein. No, we're going to know, we're going to track, and we're going to figure it out. You are here to get this right. So none of that avoiding goes on. I construct the diet, they track. It's not just about macros for the whole day. It's about macros per meal. It's a medical ketogenic diet, and we treat it that way.
Out of curiosity, which app do you suggest that they use?
So I use a professional app that epilepsy dietitians and nutritionists. So it's a professional calculator. Oh, app? You mean like the track food?
I mean, for them to track.
Chronometer. I like Chronometer. Because I can connect to it professionally. They can connect their device, their Keto Mojo device, for example, to it. And I can drag the little ketone and glucose levels down next to where their food was a few hours later and see the effects. It's just absolutely wonderful.
Do you use CGMs with your clients?
Well, here it depends. So if I have someone, I find CGMs can be useful for behavior change. It depends on the client. It depends on whether it's someone who's not making the connections between how they eat and how they feel. So if I have someone who just doesn't quite seem to be making those connections, I will recommend a CGM for at least 2 weeks and have them start to track that and see when their blood sugars go up, how they feel. And people are better. I think of it as a really great behavioral tool, but I need both. I need glucose and ketone levels in order to do a good job with people.
It's also quite good to use the CGM, just the when you said, oh, I'll throw them a low carb list and say get started with that to kind of ease it. I like putting the two together, because if they have this aversion to tracking, which fine, maybe they come from a disordered eating background and they think that it's going to set that off, which I think you and I, Nicole, would say is actually probably the other way around. Things will improve. But yes, if you can put the two together, then they see that CGM data and they go, wow, this low carb list is doing something, but it's not getting me all the way, because I'm seeing these spikes throughout the day. And then they're much more likely to come and say, right, I'm ready to track.
They had that cup of blueberries instead of that quarter cup of blueberries, and like, why isn't this working? This is on the low carb food list, right? Yeah, it helps open those conversations up. And cognitively too, the people we work with, they come to us with huge cognitive impairments from their medications. And so the idea of tracking is just like, oh my gosh, I can't even do a recipe. Like I can't even remember to, buy groceries, let alone do this. So sometimes that low carb list with a CGM is a beautiful thing.
Talking of CGMs, I'm wearing one, but of course I wear it for my type 1 diabetes, so I wouldn't be able to do without. But it influences. I know in the type 1 diabetes community, it influences behavior. That's 100% correct.
Yeah.
Any questions, Erin?
Not so far. I think we're pulling it all out of Nicole now, and helping her share her wins and what's good. I suppose actually I do have one. Maybe we could talk a little bit about the publications and contributions to the research that you know, that you've been working on, because you're not only a clinician, you are also a researcher and you have that background. And so you've been contributing wonderfully to the metabolic psychiatry literature. So do you want to give us an overview as to what those studies look like and what you're working on, maybe?
Yeah,
Well,
I would love
Erin,
to.
and sorry to interject, but there is also a current paper that Nicole and Erin are working on together. So we'll talk about that one too. Before we do it, if you don't mind, just something very quick, and we'll finish up with all the publications and the research. But something came to mind. So when you mentioned anorexia, Nicole, so you do have anorexic patients as well. So it got me thinking. So is binge eating something that you see, or even food addictions? Are they mental? I mean, is that mental illness even?
Absolutely. So, and I need to leave at 1, so we'll have to talk fast. So, but yeah, I don't have an hour and a half, unfortunately. So yes, there are case studies of people with, binge eating disorder that do very, very well. I'm thinking, is it the Carmen? I think the Carmen case studies.
Yeah.
So, yeah, they do beautifully on it. I get anorexia, but I only work with weight restored anorexia, and with weight restored anorexia, they're weight restored, but they still have a lot of the really problematic kind of obsessions and ruminations and that sort of thing. So they're still very ill and they're still very debilitated. So I work with that population. It seems to do beautiful things for that. I've worked with it with binge eating disorder, and a certain percentage of the Carmen case studies had food addiction identified. I believe it was 14%, something like that. And across the board, people did really, really well with it. Like the qualitative aspects of those case studies were like, I just suddenly didn't have a bad relationship with food anymore, or my food addiction symptoms went down, or I went from binging 14 times a week to not binging, or binging maybe once in 6 months, or something it's a very different thing that happens. So absolutely. And on mentalhealthketo.com, which is my blog, which I have not contributed to in a while, there's a nice, you can find that binge eating disorder overview with some of that research.
The binge eating
publications now.
Publication. Yes. Well, Erin I think I've only written 2 on my own, or maybe 1 on my own, 2 on my own. So I am just starting to think about myself as a researcher. I told Erin that it's really a hobby, and she informed me that that's just not a thing. Nobody's a hobby researcher, that I can't say that anymore. But so I've done some perspective articles, and I published a retrospective case study for bipolar 2 depression with a qualitative analysis with it, I think last year. We have our beautiful clinical psychology paper that we wrote introducing ketogenic diets to the clinical psychology realm, hoping that psychologists can understand their role in this upcoming treatment, that they're supposed to function on a biopsychosocial pillar of practice. This is a bio pillar, a very important one that they need to start to become aware of. So that's one of that was a very exciting paper that I wanted to get published for a long time, and Erin was with me on that and helped with that tremendously, along with the other co-authors. And let's see, we're working on a scoping review, trying to find the time to work on a scoping review that kind of looks at what are all the different diagnoses in which ketogenic diets have been used as a treatment, whether it's a case study or a study. So all the DSM-5 diagnoses that are not neurological, we are searching for ketogenic treatments around. Yeah. So that should be really good. What else am I working on? Oh, I'm working on a recovery study. So I'm collecting interviews from individuals who have recovered who identify as recovered or recovering in the process of recovering using a ketogenic diet or due to a ketogenic diet. And that is for people, I can collect interviews from anyone in the United States. So if you're in Sweden and you want to be in my study, you're going to have to come visit me, or just not, don't tell me where you're calling from. So there's that. It's an IRB approved one. And it has some pre-eligibility criteria in that I need a baseline mood assessment. So one of your therapists, one of your doctors, one of your psychiatric nurse practitioners very likely gave you a mood assessment back when you were not well. I would like to see that. And then I want to see a baseline that or not a baseline, but a follow-up that shows 50% improvement or more. And if you've got that eligibility criteria, then I collect your interview. And if your family members who watched your recovery are wanting to participate, I will collect their interviews also. And so it's got kind of a little bit of a triad of like, I say I'm recovered, my family members say I'm recovered, and my mood assessments show I am recovered or recovering. And so there's a little bit of a pre-qualification there.
It's going to be so good. I can't
It's
wait.
going to be so good. It's
So-
it's a qualitative study. And so there's coding involved, and it's not something you can just do when you got like 5 or 10 minutes. You got to get in the groove of it. So I'm working on getting that into my schedule in such a way that I can be consistent.
So how do people get in touch with you, Nicole, if they want to be part of that study?
Oh, yes. On mentalhealthketo.com, there's a big link at the very top that says recovery study. You could just click that. And then down, you read about all the criteria. And then on the bottom, there's actually a place where you can submit your baseline and follow-up scores in a secure form and give some other information. And then that just gets the ball rolling. And I'm still looking for participants. I think I have 23 interviews that I've already collected. And my goal and hope is to get 50. And I also am hoping to create a data bank of these interviews from family members and recovered individuals that other psychology researchers can access and code for their research questions. And so I'm hoping, so I need some more. I've only got 23, I think. So yes, bring them on, contact me.
Put them out there. So any last minute words before we wrap this up?
No, just thank you so much for having me. And I think that I just really so appreciate the podcast hosts like you that do all the work to arrange these interviews and have these conversations and ask these questions, because I can tell you so many people who have contacted me would have never found me without stumbling across a podcast. So thank you for your work. And I just so appreciate you.
Yeah, I second that for sure.
Thank you, Erin, for helping me out today. I really appreciate you being here as well.
No worries. Thank you for having me. And I echo everything that Nicole has said. Hopefully somebody else that has never come across this will come across you, learn from you, and then hear about us and then come and find us if they need help, or if somebody else that they know needs help and support.
All of your links will be below in the description, so people can check you out and get in touch with you and support you on social media as well. Thank you so much, and bye for now.
Bye for now.
Bye.
Thank you.